Well, it's the junction of atrial and ventricular myocardium to which the atrioventricular valves are attached. And in the normal heart, in the right AV junction, the tricuspid valve leaflets are attached. The left AV junction, it's the mitral valve leaflets are attached. And there's one point where the two junctions are contiguous, and that's at the site of the muscular atrioventricular septum. So the tricuspid and mitral annulus, or junctions, are contiguous at this point where there is the muscular atrioventricular septum. So that in an AV septal defect, the atrioventricular junction is completely different from the normal heart. Here, the aorta is wedged between the mitral and tricuspid valve with a common junction. The aorta is pushed to an anterior position. So what is clear is the AV junction in a normal heart and in an AVSD have no similarity. In all forms of AVSD, the common AV valve, which you find within the common junction, has 5 leaflets. Here's a drawing of the normal junction. And if we look at my drawing of the AVSD, the 5 leaflets are the superior bridging leaflet and the inferior bridging leaflet, which each have connections in the right and the left ventricle. That's why they're called the bridging leaflets. The left mural leaflet is confined just to the left ventricle. The right mural leaflet, or some people call it the inferior leaflet, is confined to the right ventricle. And the right anterosuperior leaflet similarly is confined to the right ventricle. 2 other things to say. The right anterosuperior leaflet and the superior bridging leaflet are in fibrous continuity with the aorta. And there are 2 basic forms of AVSD. In one, the superior and inferior bridging leaflets are joined together by a tongue of valve tissues so that the common orifice is divided into a right-sided and a left-sided orifice. And the left-sided orifice is composed of 3 valve leaflets: superior bridging leaflet, inferior bridging leaflet, left mural leaflet, and this is a commissure between the superior and inferior bridging leaflet, not a cleft. It's never a cleft, and the term should be avoided. In the other form of AVSD, there is no connection between the bridging leaflet and there's a common orifice. So you can either have a common orifice or separate right and left-sided orifices. If we look at morphological specimens, when you've got 2 orifices, the bridging leaflets here and here are joined together by a tongue of tissue, producing separate left and right-sided orifices, but clearly neither of these have an annulus. And to be called a valve, you must have an annulus. There's no annulus to the left-sided orifice. There's no annulus to the right-sided orifice. So you can't measure, if someone says, how big is the annulus? You can't say there is no annulus on the left or the right orifice. In the common orifice, again, we've got the common AV junction, but the superior and inferior bridging leaflets are no longer joined together so that there is a common orifice. So these are the 2 basic forms of AVSD. Echocardiography is the most important imaging modality, and 85% of all the essential morphology comes from 4-chamber sections and short axis sections. I just want to show you this spectacular morphological specimen. So these were cut by Yen Ho and Karen McCarthy. So this is a heart with a complete AVSD sliced postero-inferiorly in the plane of the subcostal 4-chamber view. And here we see left ventricle, inferior bridging leaflet, quite firmly attached to the ventricular septum, and right ventricle. Here's the atrial septum. This is cut now in the plane of the apical 4-chamber view, in which we see the superior bridging leaflet, the right anterosuperior leaflet, both in fibrous continuity with the aorta, but underneath the superior bridging leaflet, we see a large interventricular communication. So the subcostal four-chamber section in infants or in small children shows the inferior bridging leaflet. The apical or parasternal four-chamber sections can be used to look at the superior bridging leaflet. If we look at subcostal left oblique short axis sections through the AV junction, you can visualize the common AV junction. And during ventricular systole, when the valve leaflets when the valve is closed, you can actually image all the 5 leaflets. Here's the superior bridging leaflet, inferior bridging leaflet, left mural leaflet. You can see the 3 leaflet valve over the left ventricle, with the commissure between the superior and inferior bridging leaflet, and what is effectively a 4 leaflet valve in the right ventricle, right anterior superior, right mural, part of the superior bridging leaflet, part of the inferior bridging leaflet. So there's a beautiful demonstration of the 5 leaflet valve in an AV septal defect. Similarly, in this heart, the common AV junction, this shows beautifully the commissure, the line of apposition between superior bridging and inferior bridging leaflets, through which much of the regurgitation occurs. Again, left mural leaflet occupying about 1/3 of the diameter of the left-sided orifice, as it were. And here again, the 3 leaflet valve and the commissure between them, never a cleft. Is 3D echo helpful in diagnosis? Well, not much in infants, because the 3D probes, of course, are for use in older children and adults, whereas the diagnosis of AV septal defect is usually made in either in fetal life or in infancy, when 3D echo is less useful. Here's a couple of pictures, actually, that are not playing because the codec's out of date, but here you can see a common valve junction, aorta anteriorly with the 2 valve orifices, rather nicely shown. This, if it was playing, you'd see was a common valve orifice, but I have got one that plays here. This is a 6-month-old infant. This is a 3D echo recorded with the adult probe, but nevertheless, we can see the common AV junction, and we can see the left and right-sided orifices. There's a suggestion here that there might be an additional orifice in the left-sided valve. We knew this because we could see it very well on the 2D echo, but in fact that is an additional orifice there, picked up quite nicely on the 3D. But is 3D all that helpful in diagnosis or management? I don't think it is at the moment. Now, the fundamental classification of AVSD, according to the International World Coding Committee, which I don't sit on, is that the classification of AVSD is into 4 possibilities. You can have a common valve orifice with, a common valve with 2 orifices, and they include either the partial AVSD, the isolated primary defect, AVSD with isolated ventricular component, or the intermediate AVSD with a primary defect and a small ventricular component. The 4th type is where you have a common valve with a common valve orifice, and they are all grouped together as complete AVSD. So there are only 4 basic possibilities. Incomplete AVSD is not included in the international nomenclature and should therefore be avoided, if only to avoid confusion. If we look at the subcostal short axis view in an AVSD with 2 valve orifices, this is a routine primum defect, or in this infant with a complete AVSD, they don't look all that different, do they? But you can see the 3 leaflet left ventricular valve, which gives you the diagnosis. You can see the 3 leaflets here, left mural leaflet, superior, inferior bridging leaflet, similarly on this side. So and you can see what is effectively the common AV junction. In this primum defect, partial AVSD, the subcostal 4-chamber view shows the inferior bridging leaflet. The apical four-chamber view shows the superior bridging leaflet, and commonly underneath the superior bridging leaflet there's a recess. So the superior bridging leaflet attaches to the ventricular septum at this point. You often see this recess, which is not a VSD. It's better just to say it's a recess underneath the superior bridging leaflet. It's very frequent. For example, in this adult man, or an adult, he is male, he's 25, late presentation, primum AVSD, right heart dilatation, of course. This is the apical four-chamber view. There's the recess under the superior bridging leaflet. And even the subcostal four-chamber view in this adult patient clearly shows the two valve orifices and the three leaflet valve in the left ventricle. This is an infant with a primum defect, subcostal view showing the inferior bridging leaflet, moderately large primum defect, color flow Doppler with left to right shunting, and then parasternal or apical four-chamber view, quite different, superior bridging leaflet, recess underneath the superior bridging leaflet, and another common finding, atrioventricular valve regurgitation. You notice here the regurgitation is left ventricle to right atrium, and in fact, regurgitation to the contralateral atrium, either left to right atrium or right ventricle to left atrium, is quite frequent. You might even see that in the same patient. But this is clearly just the isolated primum defect. Official nomenclature now is partial AVSD, although there's nothing partial about the common atrioventricular junction. So partial is a bit of a misnomer, but that's what the International Committee have agreed to call it. Here's a primum defect with a small ventricular component, two valve orifices, and this is an intermediate AVSD. Primum defect with small ventricular component, and also you can see here atrioventricular valve regurgitation at two sites. Not unusual to see regurgitation, and this is sort of moderate regurgitation, right ventricle to right atrium, probably here left ventricle to right atrium. This is another form of AVSD with two valve orifices. Here, if you look at the four-chamber view, this looks to be masquerading as a perimembranous inlet VSD. No primum defect, a large ventricular septal defect apparently. But when we go to the short axis view through the left ventricle, we can see that the left-sided valve or valve orifice has three leaflets, confirming that this is therefore an AVSD with two valve orifices and isolated ventricular component, officially called AVSD with isolated ventricular component. Now, there can be many other variations in the usual morphology, which we'll deal with a little bit later on. Now, AVSD with common valve orifice is called complete AVSD, not just AVSD alone, so complete AVSD. And I'm going to go back to those morphological slices that we showed you. Remember, this mimics the subcostal four-chamber section. This mimics the apical four-chamber section. And look at these echocardiograms, obviously not from the same patient. Here's the subcostal four-chamber view, but look at the similarities here. There's the inferior bridging leaflet. Look at this atrioventricular sulcus or fold here. There it is in the echocardiogram. There's the atrial septum. There's the atrial septum. This really does mimic the echo or the morphological specimen mimics the real-time echo. And then let's go to the apical four-chamber view, which I told you was the superior bridging leaflet, and then the right anterosuperior leaflet here. Here we are. There's the superior bridging leaflet with a large ventricular component underneath it, a rather small primum defect here. So this is kind of the proof that if you use a good quality subcostal four-chamber view, that's how you see the inferior bridging leaflet. Use an apical four-chamber view, that's how you see the superior bridging leaflet. So there we are. So this seems very clear to me. So the typical complete AVSD often has a very small defect underneath the inferior bridging leaflet, which is firmly attached to the ventricular septum by either a single raphe or multiple chords, whereas, and here we can see a very small interventricular shunt on the color flow, whereas the apical view shows a bigger shunt underneath the superior bridging leaflet, as we can see here. Of course, we also need to look at the right ventricular outflow tract. Subcostal right oblique view is one good way of looking at those. And in this view, this is part of the common valve. This is the right anterosuperior leaflet attached to the aorta. This is the right mural leaflet or inferior leaflet. And the commissure between those leaflets here is producing or allowing regurgitation. There's obviously no right ventricular outflow tract obstruction. And the subcostal short axis view shows the common AV valve. We can see the right ventricular outflow tract here. Here's the pulmonary valve, so we can see as it goes in and out of the picture that this is open. The left ventricular outflow tract, subcostal long axis sections, is formed between the free wall of the left ventricle and the superior bridging leaflet here attached to the aorta. So this is superior bridging leaflet. There's obviously the ventricular component. Here's the elongated left ventricular outflow tract. So these are all the classic views that allow you to understand the morphology of an AVSD. This is an equivalent, not the same patient, 3D echo across the AV junction. It kind of shows the common AV junction and the common AV valve with its slightly thickened leaflets, but it's not so helpful because we're looking for good quality in infants, which is not achieved by the adult 3D probe, but it'll come. So an AVSD with common valve orifice is called a complete AVSD. It used to be called complete AV canal defect, which I think is acceptable because everybody knows what a complete AV canal defect is. Anyway, this is the official term. But there are also other variations in the usual morphology, which you need to be aware of. I'm not going to deal with most of these today, but you need to be aware of. You can have a huge ASD, so there's effectively a common atrium, still with separate right and left atria, however, or two separate atria if you happen to have atrial isomerism. You can have a double outlet right or left atrium. You can have left or right ventricular outflow tract obstruction. You could have a small hypoplastic superior bridging leaflet. You can have absence of the left mural leaflet so that you get a bileaflet valve, often with a parachute deformity, frequently with a small or miniaturized stenotic left-sided AV valve orifice. You can have short chords. You can have an anomalous chord sort of straddling the interventricular communication. I'll show you an example of that. You can have a dual orifice of the left AV valve orifice. You can have a hypoplastic left or right ventricle. And AV valve regurgitation, of course, occurs frequently. I just want to show you a couple of important examples of variants of a AVSD. So this is an infant, 3.5 kilograms, was presented at the MDT as a straightforward, complete AVSD. Last presentation of the morning, 10:30, people weren't concentrating properly. And I suspect the cardiologist responsible for the patient had not looked at the echo in detail himself. Anyway, so here's the common AV junction. Here is the short axis view of the valves during ventricular systole. And the thing that strikes you is the superior bridging leaflet looks very small. The left mural leaflet is quite large. The right anterosuperior leaflet is large. The right mural leaflets are good size, but the superior bridging leaflet and to some extent the inferior bridging leaflets are small. Anyway, let's go back. The surgeon comes out of the operating room after 8 hours, and he said that was impossible. He said to me, the superior bridging leaflet was unbelievably small. So, of course, when I looked back at the echocardiogram, he was right. The superior bridging leaflet was unbelievably small. He said there was a huge papillary muscle in the left ventricle, and there were very, very short chords. Here in this subcostal view, here's the huge papillary muscle. Here's the very short chords. This is the inferior bridging leaflet. Parasternal view, the left ventricle is full of muscle. You can actually see the superior bridging leaflet here is indeed very short. Effectively, this was a kind of inoperable complete AVSD. In the long axis view, look at all these muscles and chords filling the left ventricle. It's not so surprising. He had trouble during the operation. He spent 8 hours in theatre. The patient went on to ECMO. The papillary muscles also are very, very close together. This is the big one. The little one's quite big, but they're close together. So the patient then went on to ECMO, and after 14 days on ECMO, died. But had there been a better consideration of the data pre-operatively, he would have probably used a different technique to repair the AVSD and completely ignored the bridging leaflets and just closed the ventricular component and the atrial component without bothering about doing anything to the bridging leaflets. So had this been known beforehand, it could have altered the outcome, could have prevented 14 days of ECMO and the surgeon spending 8 hours in the operating theatre. This is a surgeon who's a very, very, very good AVSD surgeon. Okay, so example 2. So this is another case that was went through our MDT as a regular complete AVSD. And so the patient had surgery, did well, but came back 6 weeks later with a stenotic left atrioventricular valve regurgitation and needed a revision operation. Bit unusual for us, that. Again, a very good AVSD surgeon. But when I looked back at the echo, what you can see here is the superior bridging leaflet, but there's a very strange chord, anomalous chord going across the ventricular component, inserting into the free wall of the left ventricle. And this chord is arising, as it turns out, from the right anterosuperior leaflet. So this is a sort of a straddling chord. If we look at, in this same patient, the short axis view through the common AV valve, it's full of chords and anomalous. It looks completely different from the normal appearances of the common valve and its leaflets in a complete AVSD. Look at this area of the left, over the left ventricle. Is it surprising the surgeon found it very, very difficult to fashion a decent left-sided valve from this anatomy? It is no big surprise at all. So this, to me, was a very, very challenging case, borderline operability to get a perfect result. There are other major malformations associated with AVSD you should be aware of. Atrial isomerism, total anomalous pulmonary venous connection, a double inlet left or right ventricle when 75% or more of the common AV valve is committed to one ventricle or the other. You can have discordant atrioventricular connection, tetralogy of Fallot, the various forms of double outlet right ventricle, even common arterial trunk. I've seen 2 cases with an AVSD. And of course, you will all have seen occasional cases of coarctation of the aorta. So what is in a name? And just a final case to discuss. An asymptomatic 12-year-old is reviewed at the MDT, and the conclusion written down is AVSD for repair. That would have made me go mad anyway. Anyway, an AVSD for repair. AVSD is not a specific diagnosis. And preoperatively, the surgeon reviewed the echocardiogram, and he noted there was a primum defect, and he said to his registrar, okay, I'll do the ASD before the arterial switch. So he does the case first, and so he opens the right atrium, and eventually says, I've no idea what's going on here, find Rigby. So on my way to the operating theatre, I looked at the echocardiogram. I'm just going to show, and you may ask the question, well, what was the diagnosis that caused the surgeon to have an eruption? I'm just going to show you a still frame. So I looked at, and so what was the diagnosis? Well, there was indeed a partial AVSD, a primum defect. But there was double outlet right atrium. So here's the right atrium. Here's the right side of valve orifice. There's the left side of valve orifice. There is a double outlet right atrium. The primum defect is unbelievably small there. There's the primum ASD. There's a high velocity jet going left atrium to right atrium across that restrictive defect. And as it turned out, there was also a parachute deformity of the left ventricular valve orifice, which was effectively stenotic. Also, inevitably, the patient had pulmonary hypertension with a very loud P2, very active precordium. When I looked at the echocardiogram at the Brompton, the first 4-chamber clip appeared at clip 127, and there were only 3 of them. Granted, there was more than one echo, but the clip I looked at, you know, a 4-chamber view is the way of understanding almost all AVSDs, and there's a tendency among people now to limit the number of 4-chamber views, but do lots of other views that are not important. In this particular echo, there were 30 views of the atrial septum, but only 3 or 4 chamber views. Anyway, the surgeon operated and ended up with a very nice result, but this was not a straightforward primum defect. So I would say the key to very good medical and surgical management obviously is to examine the patient properly, because this last patient clearly had pulmonary hypertension. You need good imaging, which is interpreted correctly. You need a complete and accurate diagnosis, not just a name. It's no good calling that a partial AVSD in the last case. You have to add in the diagnosis all those other lines of diagnosis. And you need intelligent clinical decision making from a full diagnosis. So the additional benefits of a complete or a proper diagnosis applied particularly to AVSD as an accurate communication and teaching, meaningful audit, and meaningful research. Remember, AVSD alone is never a diagnosis because it lacks any specificity. So you have to be sure your diagnosis is complete. And the same can be said of an ASD, a VSD, total anomalous pulmonary venous connection, right or left ventricular outflow tract obstruction, etc. You have to be specific on exactly what is the type of RV outflow tract obstruction, what is the type of total anomalous pulmonary venous connection, which of the 5 types of atrial septal defect is the one you're talking about. So have I made AVSD simple? I doubt it, because it's never simple, but I would just quote myself now. Precision is the hallmark of excellence. And I think, in pediatric cardiology, particularly, we have to be very, very precise in diagnosis and in communication so that you get the best possible outcomes for the patients. So thank you very much for your attention.
Thank you very much, Dr. Rigby. That was a very comprehensive and interesting talk. I'm going to hand over to Mr. Rafael Guerrero, who's one of our senior surgeons, and he's been fantastic since I've come here to Alderhay, and he will continue with the chairing of the session. Thank you. Thank you so much, Dr. Rigby.
Dr. Rigby, it's been an absolute honor to have you here in Alderhay. That talk was amazing, and I can reassure you that the shops in Southport remain very posh, and it's a lovely place to go for shopping. So we will absolutely, when everything is open, we would love to have you here in Alderhay in Liverpool to show you around again and to show you our beautiful hospital. I think that we as surgeons are incredibly lucky that we are able to see the echo and have the feedback when we open the chest and look inside. And I always trying to see how can we, take photograph or images so we can feedback to our colleagues, the cardiologists, and they can correlate with the echo. And just before I pass to the rest of the team, which probably they are all daring to have questions, is I'm so pleased that you emphasize the fact that one thing is diagnosis and the second thing is morphology. And that we really need to not just give the diagnosis, but to emphasize, especially in AVSD, what's the morphology, so that we as surgeons, we can reconstruct what we need to do. And a very quick, from my experience, what I found is, and I try to teach to the juniors, etc., is that when we look at the echocardiograms, one is want to see, right, so is there a VSD or not, the size of the VSD. But once that we open the chest and open the heart, what I found and more I can see is what I call it asymmetric VSD, meaning sometimes it's right in the middle, sometimes the VSD is more scooped towards the aortic tract, and sometimes more scooped towards the posterior part. And that helps us to make the shape of the patch, and can we do a modified single patch technique. But I'm delighted that you give us this talk. And before anything, I'm going to pass to the rest of my colleagues if they want to ask any questions. But thank you again for your time.
No, thank you for the invitation.
Rafael?
Who is the first one?
Rafael, can you hear me?
Yes.
Hi. So I take the opportunity to chip in quickly. Dr. Rigby, I'm Attilio Lotto, one of the other surgeons working at Alderhay. Thank you very much for delivering this exceptionally good presentation and account of complete AVSD. I have actually one comment. First of all, actually, I'm really pleased that in your example 1, you pointed out about the subvalvular apparatus, because throughout my years repairing complete AVSD, I found actually the most challenging one for me were the one where I underestimated the position of the papillary muscles and how the chordae length or shortened go to the superior and inferior bridging leaflet. And the one that I found actually that when the papillary muscles are slightly joined more together are the one actually that then present more acceleration in the inflow after the operation. And I have in a couple of times used another technique of augmenting in those cases the cleft, instead of closing, augmenting the cleft with a patch, so to keep the papillary muscles a little bit farther apart than they would come if I close the cleft completely. The second one, actually, it's still about the cleft. Actually, we have learned from the past, actually, that leaving the cleft open at the first operation might lead to further regurgitation later on in life. But there is a circumstance where we still think about leaving the cleft open, which is in the presence of a double orifice valve. And I was just wondering, in your huge experience, if you can make a comment on closing or not the cleft in double orifice and what the faith in the follow-up. And I thank you again for a fantastic presentation.
My view is, based on, because I'm not a surgeon, so I don't operate, but my view is that if you've got a double orifice and the left-sided valve leaflets are not particularly regurgitant, it's better probably not to not to suture the cleft, because I think, first of all, it's very difficult because when you've got a double orifice, the anatomy of the left side of the valve often bears no resemblance to a normal valve, And to mess around with that valve, if it's already functioning reasonably well, is probably unwise. So I think where there are clearly problems with the left side of valve, and the left, of course, the left ventricular valve, if you want to call it, is the key to the outcome, isn't it, of surgery. And if it is small or difficult, sometimes it's better to leave it alone, I think. You may have to reoperate later, but I think it's best to leave it alone. Any other questions for anybody? If there's not, I think they're calling me from the cath lab.
Well, no, thank you, Dr. Rigby. I think that probably what we will do is anybody have more questions, we will collect them and send it to you.
Yeah.
But once again, I think have a great day, and we're looking forward to see you again.
Yeah. I've just written. No, I was invited to write a review of AVSD for a journal, which was actually paying tribute to Bob Anderson. So I think I forwarded this paper this morning to Garima.
Yes.
One of your teams.
Yes. Dr. Rigby, I've just put that on the files on the Teams, and it's for everyone to read. It's available on the Teams right now.
Thank you, Garima. I'm not blowing my own trumpet, but I think it's quite a comprehensive review of morphological aspects of AVSD. So as soon as I made the effort to write the 5,000 plus words, it'd be nice if somebody reads it, you know. All the best to all of you. Thank you for the invitation.
Thank you, Dr. Rigby.
Thank you for sharing, and thanks for your time. We hope to hear more from you, sir. Thank you.
Bye-bye.